Good morning, everyone. Yesterday I discussed thyroid pharmacology, and today I will discuss 10 years question bank. Few questions are repeat questions, few are new questions, and my suggestion is after going through thyroid pharmacology chapter from any book, you should watch this video. So let's start. First question, short essay type, management of myxedema coma. Yesterday I discussed, and again I am telling you under two headings: general management and specific management. Under general management, write hospitalization, control airway, breathing, circulation. Next, correction of any metabolic disturbances like hyponatremia, hypoglycemia. Next, treat any precipitating factors. Next, if required, you should give antimicrobial agents. And last, management of other complications. And next, under specific management, number one, you should give levothyroxine or T4 500 microgram IV bolus, followed by 50 to 100 microgram, simply 50 microgram IV daily till acute crisis is over. This is the first specific management. And second, you should give IV hydrocortisone, that is one steroid. Initially, 100 milligram IV bolus, followed by 50 milligram TDS. Okay, so this is the management of myxedema coma. Second, short essay type question, 10 marks, management of thyroid storm or thyrotoxicosis or thyrotoxic crisis. Again, first drug will be here general, again general and specific or definitive management. Under general management, hospitalization and supportive care like antibiotics, control of airway breathing circulation if required, antibiotics, anxiolytic, etc. etc. And the specific management, you should write first write propranolol. First write propranolol. This is non-selective beta blocker. In thyroid storm, there is sympathetic stimulation, which has adverse effect on heart, mainly palpitation, angina, arrhythmia. So first give propranolol, number one drug. And this is the first drug used in thyrotoxicosis. Or you can tell drug of choice in thyrotoxicosis. Answer is propranolol. And antithyroid drug of choice in thyrotoxicosis. Answer is propylthiouracil. I'm coming. So in emergency hyperthyroid condition, that is thyroid storm management, first give propranolol. Orally, you can give 40 to 60 milligram 4 hourly or 2 milligram IV 4 hourly. So this is the first drug. Okay. Second drug, propyl thiouracil. Propyl thiouracil 600 milligram loading dose by nasogastric tube or rectal route. Right nasogastric tube preferred. And followed by that, after giving loading dose, 300 milligram 6 hourly. Okay. And after 1 hour, give saturated solution of potassium iodide, 5 drops orally. 5 drops saturated solution of potassium iodide and give it after that 6 hourly. And last drug, another steroid, dexamethasone. You can give it orally or by intramuscular route. Dose is 2 milligram orally, 6 hourly. So this is very easy to remember. Thyroid storm management, PPP model, P for propranolol, P for propyl thiouracil, and another P for potassium iodide. And after that, model M for methazone, that is dexamethasone. So management of thyroid storm is under PPP model. There is mnemonics. Okay. Next question. Question number 3. Short note carbimazole. So you should write under following headings. Number 1, group, antithyroid group, antithyroid drug. You can call this group thiamide. Okay. Number 2, mechanism of action. Carbimazole mechanism of action during thyroid hormone synthesis. This drug inhibits thyroid peroxidase enzyme. This drug inhibits thyroid peroxidase enzyme. Thyroid peroxidase enzyme is responsible for oxidation, iodination, and coupling. So this drug is actually thyroid hormone synthesis inhibitor. Number 3 point, use or indication. Use or indication. So where this carbimazole is used, in which conditions? Thyrotoxicosis, thyrotoxicosis or hyperthyroid condition. Okay. First use. Second use, before performing thyroidectomy or thyroid surgery, carbimazole is used in young patients. Okay. And number 3, to make patient euthyroid before application of radioactive iodine. So hyperthyroid condition, before surgery, before radioactive iodine therapy. These are 3 uses. Side effects of carbimazole. Side effects. Next point, side effects. Most common maculopapular rash, most serious granulocytosis, and apart from this, GIT upset, alopecia, hypoglycemia, etc., etc. But these are 2 very important side effects. And number 5, if possible, write pharmacokinetics. Actually, you should write this point number 3, number 4 use, number 5 side effects, pharmacokinetics under this heading. Write these subheadings: absorption, distribution, metabolism, excretion. Okay. Well absorbed orally, distribution, well distribution. Metabolism mainly metabolized in liver, excretion mainly excreted through kidney. Finish. Short note. And you should follow these points: group, mechanism of action, pharmacokinetics, use, side effect. In this question, next question, propyl thyrosis short note. Here, you also apply these headings. Okay. And if question is propyl thyrosil, group, mechanism of action, use all are same, but side effect is slightly different. Propylthyracil side effect is hepatotoxicity, aplastic anemia. It may cause aplastic anemia. And apart from this, arthritis, vasculitis, these are less common side effects. Okay. And I discussed this pregnancy. Regarding pregnancy, carbimazole is used in second and third trimester, and propylthyracil is used in first trimester in hypothyroid condition. Okay. Now coming to this next question, radioactive iodine, right? Radioactive iodine is given by oral route, right? The same group, mechanism of action, use, side effect, and add two additional points. Is the advantage of radioactive iodine and disadvantage of radioactive iodine. Okay. Use need not to write pharmacokinetics for radioactive iodine. Just write add new 2 points, advantage and disadvantage. And is yesterday I discussed advantages. Few advantages are simple, convenient, inexpensive. First point. Second point, during radioactive iodine therapy, no injury to parathyroid gland or recurrent laryngeal nerve, which are present close proximity to thyroid gland. And number 3 point, once hyperthyroidism is controlled, once patient becomes euthyroid, cure is permanent. This is the third point. And disadvantage, first point is risk of hypothyroidism. Risk of hypothyroidism. If hypothyroidism occur, this will be permanent. That is dangerous. And number 2 point, contraindicated in pregnancy. Contraindicated in pregnancy. And also not suitable for young patient. Young patient are not suitable. And number 4 point, all of you know, increased risk of few cancers, stomach, kidney, breast, mainly. So these are advantages and disadvantages. So write the short note of radioactive iodine under these headings. Number 1, group. Number 2, mechanism of action. Number 3, indications. Number 4, use. Number 5, advantages. Number 6, disadvantages. And last, you can write in any short note in radioactive iodine, in propylthyracil, in carbimazole, there is contraindication. Okay. So one contraindication is hypersensitivity, another contraindication is for carbimazole, another contraindication is first trimester of pregnancy. For propylthyracil, an added contraindication is second and third trimester of pregnancy. And for radioactive iodine, contraindications are pregnancy, young patients. Okay. So now, next question, number 6. This may be 5 marks or 10 marks. Discuss the steps of thyroid hormone synthesis. Steps. So number 1 step is iodide trapping. Number 2, thyroid hormone synthesis. Number 3, thyroid hormone release. And number 4, peripheral conversion of T4 to T3. And next question is mention different drugs which block these steps. First step is iodide trapping. This is inhibited by thiocyanate and perchlorate, these drugs. Number 2 is thyroid hormone synthesis inhibitor or thyroid peroxidase inhibitors. This step is inhibited by carbimazole, methimazole, propylthyracil. Number 3, release inhibitors. These are also known as thyroid constipating agents. Thyroid hormone release is inhibited from thyroid gland to blood, and here drugs used are iodides, sodium iodide, potassium iodide, and Lugol's iodine. Lugol's iodine. Lugol's iodine is nothing but 5% iodine in 10% potassium iodide. And number 4 is radioactive iodine, that is 131. Sorry, uh, if the question is classification or enumerate antithyroid drugs, these are the classification, and number 4 will be iodine 131. But here question is steps of thyroid hormone synthesis and different drugs which block these steps. So here number 4 drugs will be peripheral conversion of T4 to T3 inhibitors. Drugs used PTU, propyltyrosine, again additional role. Apart from this, propranolol, steroids, amiodarone, amiodarone. These drugs are used to block the peripheral conversion, number 4 step. So this is the answer. Next question. Explain why. That is very interesting question. Explain why Lugol's iodine is given in pre-operative preparation of thyroid surgery. Before thyroid surgery, before 2 weeks of thyroid surgery, start Lugol's iodine. Okay. Iodine is thyroid constipating agent, and role of this drug is this drug inhibits release of thyroid hormones. So why this? What is the logic behind this use be 2 weeks before surgery? Number one, this drug inhibits release, so thyroid function suppressed. Number two, this drug or iodides inhibit or decrease vascularity of gland, thyroid gland. Vascularity of thyroid gland is decreased. What is the advantage? During thyroid surgery, there is less chance of bleeding in operation table. And number three logic is due to thyroid function suppression, gland size, thyroid gland size will be decreased. Gland becomes more firm. So during thyroid surgery, it's easy for surgeon to manipulate the thyroid gland to hold the thyroid gland. These are three logics why lugolcidine is given preoperatively. Next question is levothyroxine. Levothyroxine, that is T4, is preferred over liothyronine, that is T3, for treatment of hypothyroidism patient, in spite of latter being more efficacious. This T3 is more efficacious compared to T4. T3 is short-acting drug, more potent drug compared to T4. But T4 is used in hypothyroidism. This is the question. Answer is there are few points. Number one, T3. T3 half-life is less. So short-acting, rapid onset of action, and high chance of cardiovascular complications, mainly angina, arrhythmia. Okay. Number two point is as T3 is short-acting drug, so T3 is given multiple times in a day, but T4 is given only once daily. Dosing schedule of T4 is once daily. That is the advantage. More convenient to patient. Number three point is stability. Stability of T4 preparation is more. So T4 preparation is more stable. Number four, less important point, that is cost. T4 cost is less. These are 4 points mainly. And you can add another point that when you prescribe T4, T4 is converted to T3 in our body, peripheral conversion. So you'll get T4 and T3 both drugs. So these are the advantages Why T4 is used, not T3 in hypothyroidism, but T3, as T3 is short acting, remember one line, T3 is short acting, so T3 is used in hypothyroid emergency. T3 can be used. So only use of T3 is hypothyroid emergency, that is myxedema, coma. Otherwise, T3 is not used. Mainly, T4 is used to treat hypothyroidism. Next question. Iodides are fastest acting antithyroid drugs, but they have limited use in the management of hyperthyroidism. Hyperthyroidism manage করতে iodide use করা হয় না, but iodides are fastest acting drugs. Why? কেন? Use করা উচিত ছিল তো। So question may come in different format. Explain why long-term monotherapy with iodine is not practiced in thyrotoxicosis or hyperthyroidism patient. Question may come in this form also. Answer 2 points, mainly two logics. Number one, iodide monotherapy, only iodide is used. Suppose what will happen after 2 to 8 weeks? After 2 to 8 weeks, thyroid gland is likely to escape from iodide blocking effect, and thus long-term administration is not associated with pharmacological benefit. Just note down these lines and write in your exam. Number 1 point. And number 2 point, iodides, they inhibit only release, not synthesis. They inhibit only release. So synthesis continues. Okay. So sudden withdrawal of iodide may lead to development of severe exacerbation of symptoms, as the thyroid gland would cause release of thyroid hormones in greater quantities. Again, I'm telling you, because they are not inhibiting the synthesis of thyroid hormones, they are only inhibiting the release. So synthesis continues and thyroid hormones are stored in large quantities in thyroid gland. Okay. So these are two reasons why iodide monotherapy is not used to treat hyperthyroidism. Next question. Explain why propranolol is used in thyrotoxicosis. So thyrotoxicosis means T3, T4 high, and when T3, T4 is high, then sympathetic stimulation occurs, mainly affect cardiovascular system, palpitation, angina, arrhythmia, etc., etc. So propranolol is used by two reasons. Number one, number one reason is propranolol is beta blocker, so they can decrease heart rate by acting upon beta 1 receptors of heart. So palpitation will be relieved. And another point is they also relieve tremor, that is due to beta 2 stimulation of skeletal muscle, and propranolol block these beta 2 receptors. So propranolol relieves palpitation, tremor. These are features are actually sympathetic stimulation. First point. And number 2 point, propranolol inhibits peripheral conversion of T4 to T3. T3 is short acting, more potent, so high chance of cardiovascular complications. So propranolol blocks this step also, that is peripheral conversion of T4, and this step is stimulated by one enzyme, deiodinase. These are the two advantages of propranolol. For this reason, propranolol used in thyrotoxicosis. Next question. Propyl thyroxine (PTU) is used in hyperthyroid pregnant women. Propyl thyroxine crosses placenta less, not zero, less compared to other two drugs of the same group, carbimazole, methimazole. So crosses placenta less. This drug is non-teratogenic. So for this reason, propyl thyracil is used in hyperthyroid condition. But important point is this is used only in first trimester before organogenesis used only in first trimester. Pregnant hyperthyroid woman, first trimester, drug of choice propyl thyracil, PTU. PTU पहले ट्राइमेस्टर पे यूज करो. Okay, PTU. And in second and third trimester, propyl thyracil is not used because after first trimester, fetal liver has been developed, and all of you know PTU has hepatotoxic side effect. So PTU will cause damage of fetal liver. For this reason, PTU is not used in second and third trimester. And in second and third trimester, carbimazole is used. So question was finally PTU is used in hyperthyroid pregnant women, less crosses placenta, and non-teratogenic. These are the two main reasons. Next question. Explain why. Carbimazole takes weeks to reduce the clinical features of hyperthyroidism. Carbimazole is prodrug converted to methimazole. This is second point, not very important point. And first point is most important point why carbimazole takes weeks to reduce the clinical features of hyperthyroidism. Carbimazole inhibits only synthesis of thyroid hormone. Only synthesis of thyroid hormone they inhibit, not release. Carbimazole has no effect on release of thyroid hormone. So already synthesized thyroid hormones are releasing in blood from thyroid gland, and carbimazole has no effect on this release. So from thyroid gland, T4, T3 are releasing in blood, and T4 has long half-life. So to reduce the effect of thyroid hormones, carbimazole takes time because, again, because they have this drug, carbimazole, methimazole, these drugs have no effect on release. Number one, and number two, that is not important. You should write this point only. That will enough. Okay. Next question. Slowly. Explain why. Carbimazole should be withdrawn few days, usually 7 days, before radioactive iodine treatment and reinstituted few days, usually 3 days after it. So radioactive iodine therapy হবে তার আগে patient is hyperthyroid, patient is on carbimazole. Before 7 days of radioactive iodine therapy, carbimazole should be stopped, and after 3 days of radioactive iodine therapy, again carbimazole will be started. Why? This is the question. This is the question. Explain why. Okay. Now, what will be the answer? Carbimazole again. Carbimazole, they inhibit synthesis of thyroid hormones. Only synthesis of thyroid hormones. Okay. And radioactive iodine, that is iodine 131, radioactive iodine acts by generating beta particles in the thyroid gland. For this action, first of all, iodine 131 is stored in colloid. by incorporation in thyroid hormones. Okay. It means that iodine 131 behaves like normal iodide and forms thyroid hormones which contains iodine 131 instead of normal isotope. Thyroid hormones নর্মাল আয়োডিন দিয়ে সিনথেসাইজড হয় কিন্তু আয়োডিন 131 যখন রেডিও অ্যাক্টিভ আয়োডিন থেরাপি চলছে তখন থাইরয়েড হরমোনের মধ্যে কে চলে আসছে আয়োডিন 131 বিটারে এমিট করবে ডিস্ট্রাকশন অফ দ্য ফলিকলস এটাই ওর মেকানিজম অ্যাকশন সো যদি আমি কার্বিমাজল স্টপ না করি ইফ উই ডোন্ট স্টপ কার্বিমাজল বিফোর রেডিও অ্যাক্টিভ আয়োডিন থেরাপি হোয়াট উইল হ্যাপেন when iodine 131 gets incorporated in thyroid hormones, it can emit radiations like beta rays, I have told you. Its physical half-life, iodine 131, half-life is around 8 days. Okay. So its therapeutic effect takes months to manifest. Thus, to keep the patient euthyroid till effect of iodine 131 starts, carbimazole-like drugs, carbimazole, methimazole, are reinstituted 3 days after starting iodine 131. Am I clear? Not. Okay. So first we withdraw. Why withdraw? Because carbimazole inhibit only release. Sorry, carbimazole only inhibits synthesis. So carbimazole inhibits iodine 131 incorporation in thyroid hormones. তাহলে বিটা এমিশন হবে না, iodine 131 এর অ্যাকশন হবে না। This is the reason behind withdrawn and reinstituted. Why reinstituted? Because iodine 131 এর half-life 8 days. So anti-thyroid effect start হতে around months, 1 month, 2 months এরকম লেগে যায়। সো ওই টাইমটা 1 to 2 months পেশেন্টকে হাইপারথাইরয়েড ফেলে রাখতে পারি না, ইউথাইরয়েডে রাখতে হবে। সেই জন্য কার্বিমাজলটাকে আবার রিইনস্টিটিউট করা হয় যতদিন না আয়োডিন 131 এর অ্যাকশন স্টার্ট হচ্ছে। ব্যাস, দিস ইজ অ্যান্সার। ওকে, নাও come to long essay type 15 marks question. This is one sample question I have taken from KD Tripathi 8th edition, question number 18.1. 18.1. Okay. If you have Tripathi, go through it. Question is, a 20-year-old girl diagnosed as a Kesha recent onset Graves' disease with mild diffuse pulsatile thyroid enlargement. She was treated with tablet carbimazole 5 milligram, 5 milligram tablet, 2 tablets TDS. That is total six tablets per day. So patient is hyperthyroid patient and she is on carbimazole. Her symptoms started subsided after 2 weeks. Few moments before I discussed why carbimazole takes time to start action. Now, after 2 weeks, symptoms started subsided and were fully controlled after 3 months. Okay, so now patient is euthyroid, no problem. The thyroid swelling also subsided and she was maintained on a dose of carbimazole 5 milligram BD. So dose কমিয়ে দেওয়া হয়েছে 5 milligram 2 tablets TDS চলছিল. After relieving of symptoms, now patient is on 5 milligram tablet BD, one tablet, one tablet. Okay. Okay. Next, after 1 year, she noticed the neck swelling reappearing and her body weight increased by 2 kg in the last 1 month and without any symptoms of thyrotoxicosis. So, what is the problem now after 1 year? After 1 year, she is developing few symptoms of hyperthyroidism again. Okay, so this is the question. Now, read carefully. This is the story actually. Now, carefully read this question. Why was the initial response to carbimazole delayed? So here I discussed the answer. Carbimazole takes weeks to reduce the clinical features of hyperthyroidism. This is the question I have already discussed. Next question. Could any additional medicine be given to her initially, that is, initially, before 1 year, to afford more rapid symptomatic relief? Yes. Which drug? In hyperthyroid condition, what happened? T3, T4 cause cardiovascular complications like palpitation, tremor. So we can give additional medicine that with carbimazole, that is propranolol. Okay, this is the logic I have discussed in previous short note or explain why. Okay, so this question is over. Next question. Next question. What was the cause of reappearance of neck swelling and her condition after 1 year? Why? Neck swelling reappearing, why? Because carbimazole কি করবে? T3, T4 অ্যাকশন সিনথেসিস ডিক্রিজ করবে। ডিক্রিজ করলে কি হবে? T3, T4 নর্মালি কি করে? ফিডব্যাক ইনহিবিশন। ফিডব্যাক ইনহিবিশন অন পিটুইটারি। Normal normal T3, T4 normally cause feedback inhibition and decreased release of TSH normally. But here, when patient is on carbimazole, T3, T4 decreased, so feedback inhibition, no feedback inhibition, resulting in increased synthesis of TSH, and TSH stimulates thyroid gland, resulting in reappearance of swelling. Okay, this is the reason. Cause of reappearance of neck swelling. Okay. What measures need to be taken at this stage? At this stage, what will you do? Since the disease activity in Graves' disease, neck swelling may decline after some time, the maintenance dose of carbimazole needs to be adjusted from time to time according to the clinical status and laboratory thyroid status. So carbimazole এখানে চলছিল 5 মিলিগ্রাম বিডি করে, তাতে টিএসএইচ ইনক্রিজ টিএসএইচ। ওকে, তাহলে আমি কি করতে হবে? টিএসএইচ যদি ডিক্রিজ করতে হয় টাইম টু টাইম আমাকে patient requires temporary discontinuation of carbimazole followed by a lower maintenance dose, 5 milligram BD. 5 milligram BD dose is actually after 1 year overdose. Okay, so now depending upon situation when TSH is increased, our duty is to decrease, first discontinue for few days and then start again carbimazole with lower dose, maybe 5 milligram OD. Next question, all of you know, enumerate antithyroid drugs based on mechanism of action. Drugs inhibit iodide trapping, thiocyanate perchlorate. Drugs inhibit thyroid hormone synthesis, propylthiosyl carbamazole, methimazole. Number 3, drugs inhibit release, iodides, lugolsardine. And number 4, drugs destroy the thyroid tissue, that is radioactive iodine. Okay, finish. Next, describe the drug treatment of acute thyrotoxicosis. I have already discussed. How do you prepare the patient for surgery? All of you know lugolsardine is given 4 weeks before surgery. Sorry, 2 weeks before surgery. Okay. And 2 to 4 weeks. You can give start with 2 to 4 weeks before surgery. Next, before starting MCQ, first tell me this clinical condition, answer of this clinical condition. A patient presented to OPD with swelling of neck as shown in the picture. Okay. He complains. He complains. 1 minute. He complains of decreased appetite, fatigue, cold intolerance. এখন আমি জানি না hyperthyroid না hypothyroid জানি না. He has gained 8 kg of weight in last 4 months. Now, confirmation of diagnosis. Thyroid function test revealed normal T4 but elevated TSH. That is subclinical hypothyroidism. Okay. TSH elevated means T4, T3 should be decreased. Hypothyroidism, but here normal T4, normal T4. So condition diagnosis is subclinical hypothyroidism. Which drug will you prescribe? Liothyronine or T3, carbimazole, steroid, L-thyroxine. Liothyronine, T3, and T4. Among these, preferable drug is T4. Okay. So first option is wrong. Second option may be correct. Carbimazole is not used because patient is hypothyroid. Carbimazole is anti-thyroid drug, so carbimazole is not. So answer A is wrong. Answer C is wrong. And steroids. Steroids prevent only peripheral conversion of T4 to T3. So these steroids will not improve hypothyroid condition. So here answer is levothyroxine. Okay. Next, another question. Exophthalmos, enlargement of thyroid gland. Now the question is, a 40-year-old male patient, 40-year-old male patient presented to emergency as shown in picture, fever, extreme restlessness, confusion, and marked weakness. Okay. On examination, severe tachycardia and blood pressure 170 by 110 was noted. ECG revealed presence of atrial fibrillation, that is one type of arrhythmia. Okay. So patient is suffering from hypertension, tachycardia, and arrhythmia. So all of you know this is due to thyroid hormone, mainly T3. Which among the following is only life-saving drug that should be given immediately to that person? অনেক ড্রাগই দেওয়া যেতে পারে, but immediately, ফার্স্ট ড্রাগ থাইরোটক্সিকোসিস কেস, ফার্স্ট ড্রাগ কোনটা দেবো? কার্বিমাজল, রেডিওঅ্যাক্টিভ আয়োডিন, প্রোপ্রানোল or লিওথাইরোনিন? Liothyronine answer is totally wrong because this is hyperthyroid condition. Don't prescribe any thyroid drug. So liothyronine is answer is wrong. Propranolol, yes. Propranolol can be given non-selective beta blocker. I already discussed the this drug helps to prevent tremor, palpitation. Okay, radioactive iodine. In emergency condition, radioactive iodine is not used. I have told you, half-life is 8 days. So radioactive iodine start action after 1 or 2 months. So radioactive iodine is not used this emergency condition. And carbimazole is anti-thyroid drug, very good drug, but carbimazole takes time to start action, anti-thyroid action. So carbimazole is anti-thyroid drug, radioactive is anti-thyroid drug, both drugs are anti-thyroid drug, but here life-saving drug, which drug is given? To prevent arrhythmia, palpitation. That is the answer is propranolol. This is the treatment of choice in emergency condition, first drug. Okay. Next, start few simple MCQs. Actually, these are not important for your second prop MBBS exam. This is very tough MCQ. All of the following reduce T4 absorption. All drugs reduce T4 absorption except one. Okay. So I'm telling you, iron salt, raloxifene, colsevelam, bile acid binding resin. These three drugs, raloxifene will be discussed, that is selective estrogen receptor modulator, raloxifene. Iron salt is another drug. Colcevalam is bile acid binding resonance. These three drugs reduce T4 absorption, okay, except metformin. So metformin has no role. So here, MCQ 6 answer is metformin. This is very tough question. Next question, all can cause hypothyroidism. All can cause hypothyroidism. PAS, that is para-amino-salicylic acid. Okay. First option, captopril, all of you know. Calcium channel, captopril is, sorry, is C inhibitor. Uh, lithium. Lithium is used to treat mania, prophylaxis of mania. And amiodarone is another drug. So now, all can cause hypothyroidism. Let's discuss one by one. First, start with lithium. Always remember one very important side effect of lithium is hypothyroidism. Okay, so lithium causes hypothyroidism by inhibiting hormone synthesis and hormone release. Okay, so lithium causes hypothyroidism. Amiodarone, this is very interesting. Amiodarone causes both hypothyroidism and hyperthyroidism. Okay, in amiodarone, there is high concentration of iodine. So, amiodarone, after metabolism, amiodarone releases iodine, and iodine causes Wolff-Chaikoff effect. Yesterday I discussed Wolff-Chaikoff effect and resulting in hypothyroidism. And another point, amiodarone contains iodine, so increased after metabolism of amiodarone, iodide concentration in blood will be increased, and increased iodide causes increased hormone synthesis, increased thyroid hormone synthesis, resulting in hyperthyroidism. So amiodarone causes both hypo and hyperthyroidism. This is very interesting. So here question is hypothyroidism. So amiodarone causes hypothyroidism. Yes. Okay. Para-amino-salicylic acid. This is very tough for you. Para-amino-salicylic acid also causes hypothyroidism. So here answer is captopril. Okay. Here answer is captopril. Okay, next MCQ is not used in thyroid storm. Very easy question, all of you know. Propanol is used, potassium iodide is used. Now about diltiazem, that is calcium channel blocker. Diltiazem is also used when propanol is contraindicated. For example, in asthma patient, propanol is contraindicated. Diltiazem plays the same role as propanol. They also inhibit heart rate, decrease palpitation. So answer is reserpine. Reserpine is actually antihypertensive drug that is not used in thyroid storm. Okay. This is a tough question. And next question is all are rare side effect of thioamide group except actually question is all are rare but fatal or serious side effect. Actually MCQ is all are rare but fatal or serious side effects of thioamide group except thioamide group means propyl thiouracil, carbimazole, methimazole except propyl thiouracil, carbimazole, methimazole. These drugs cause agranulocytosis, aplastic anemia, liver toxicity. I already discussed this. So answer will be lung fibrosis. Lung fibrosis is not caused by thioamide group. Next and last question is aspirin should be avoided in hyperthyroid patient. Aspirin is very commonly used as painkiller. This is one NSAID. So another very important use of aspirin. Aspirin is drug of choice in prophylaxis of myocardial infarction. So your question is aspirin should be avoided in hyperthyroid patient. The statement is true or false. Statement is true or false. Aspirin causes increased T4 level in blood. Aspirin causes increased T4 level in blood. How? Aspirin removes T4 from thyroxine, thyroxine binding globulin. T4 binds to thyroxine binding globulin, that is one protein in blood. Aspirin removes T4 from this protein and increased blood levels. So in hyperthyroid condition, already T4 is raised. In that condition, aspirin is not given as it increases T4 level. So should be avoided. This statement is true. Okay.